Thank you so much. It's really a pleasure to be back in Tanzania. I was, as the MC said, I was here 3-4 years ago, and I spent very good 3 years at Ocean Road and Muhimbili as a resident in clinical oncology. This is my first time to be back in Tanzania after those years, and I'm happy to be back during a conference that is very I would say near to my heart, Choosing Wisely. And in this morning, I'm going to be sharing with you what is Choosing Wisely and why are we here, why do we do all we are talking about right now. These are my names. I'm a senior lecturer at University of Rwanda, but also a consultant clinical oncologist at Rwanda Military Hospital. So the talk of this morning about choosing wisely, I'm going to be sharing with you choosing wisely in general, but specifically I'll be talking about choosing wisely Africa and how it came about. So choosing wisely as a concept, it started from mostly high-income countries, the United States, Canada, and then it moved to other countries and other societies. But specifically for oncology, which we're going to be talking about, is generally an initiative that is trying to initiate a conversation between patients, healthcare providers, but also to a large extent health policymakers that we have in our different countries. And this discussion is about the proper use, especially for low and middle income countries like us in Tanzania or in other countries, in most countries in sub-Saharan Africa. It's about the discussion about how we go about our clinical care and how we treat our patients. And the target for this, as I said, patients, clinicians, but also health policymakers in our different countries. So the major emphasis is on the practices or interventions that are of low value, costly, but also sometimes very harmful to our patients. And I'll be giving you some of these examples as I go on. For example, like this paper that looked at the aggressive care at the end of life for young patients with cancer. We all know that if you have, let's say someone with 30 years old breast cancer who is at end of life, sometimes we are still pushing for aggressive treatment because we know this is a young person, we can do something. We always say there's something that we can do, but when you look at it, sometimes we are actually treating ourselves as clinicians. So in choosing wisely, we are saying choose wisely even when you think you can still do something for these young patients. And also, for example, in breast cancer, we know that for early breast cancers, sometimes you don't need really to do aggressive imaging to look for metastatic diseases. But we know that in our practice, sometimes we have requested, CT scan, PET scan for early stages of breast cancer. So all these are the practices that we are saying should be stopped. And this is why we are saying choose wisely on the images you're requesting, the intervention that you're doing. And as I said, the emphasis really is about the value in cancer care. And when we talk about value in cancer care, we usually put it in this equation, which is, the quality of care that you're giving, that is, the benefit, quality of life, survival. And then you subtract the adverse effects of your intervention. What are the side effects of the chemo that you're giving? What other adverse features that this treatment or intervention that you're giving the patient is causing to the patient, and then over the cost of the intervention that you're providing to your patient. So as any other mathematical equation, if the costs of care is very high, then the value of care is low or is minimal. But if the quality of care that you're providing is high, and with the minimal side effects and low cost, then you know that you're providing a high value care to your patient. So what we are emphasizing is that we increase the quality of care that we are providing, minimize the side effect, but also reduce the cost of care or intervention that we are giving to our patients. But we know that this is not the reality currently. You all know that sometimes there are these drugs, as I'm going to give you some of these examples, that we give to our patients, and we know scientifically that these drugs actually only add few days or months to our patients, yet they are costing millions and millions of Tanzanian shillings, for example. So what we are saying is these are really not, they're not helping us to provide high value care to our patient and should be avoided, as I'm going to show you some of these examples. But also we know that there are some drugs or interventions. So for example, if you have someone with metastatic disease, at the end of life, who is having, let's say, a liver lesion, this is a patient that you're not going to really do a surgery on. But sometimes we see, for many reasons that I also share, some patients are taken to theater for operations that are not really clinically motivated, but rather financially motivated, either for personal financial interest or for the institutional financial interest. So these are things that we are saying should be stopped on the continent. So choosing wisely is applied in several aspects of cancer continuum, from research to screening and early detection, to diagnosis and treatment, but also funding of healthcare at large. Even when we are funding, and this is for policymakers, when you're funding for cancer care, you have to choose wisely how you spend the little resources that you have in the country. You, for example, are not going to be spending a lot of money on targeted therapy, funding targeted therapy, if you cannot even afford the traditional chemotherapies, or if you cannot, you can't, allocate money for molecular testing or fancy PET scan when you cannot afford to have a CT scan in your hospital. So even in funding for healthcare or cancer care in particular, you have to choose wisely how you allocate the little resources that you have. The same applies to healthcare workforce planning. If you have been following news across the region, you know that, for example, in Kenya, there are doctors who are not employed right now, yet they have a lot of need for doctors. So that is also poor planning in terms of healthcare workforce. So even that, you have to choose wisely how you plan that. So as I said, choosing wisely was started really in high-income countries, specifically in the United States by the ASCO and ASH, which is the American Society for Hematology and the American Society for Clinical Oncology. They published their lists of practices that they thought should be stopped in the United States for those two societies. And then the Canadian colleagues also published their Choosing Wisely list. And then the Indian colleagues were the first ones outside high-income countries to publish their lists. And really, this is what motivated us as African oncologists to also come up with the Choosing Wisely Africa list. And the motivation was none other than knowing that the cancer burden in Africa is growing, and Africa at large, specifically Sub-Saharan Africa, has limited resources for cancer care. For healthcare, but in particular for cancer care, with also limited workforce. And this combination of these three really pushes us to think twice or choose wisely when we are thinking on how we're going to take care of our patient. So we asked ourselves whether choosing wisely is really relevant in African context, and what we came out was, yeah, it's really indeed relevant, and that is possible to deliver the best care at the lowest cost possible by avoiding financial toxicity to patients, family, but also society. So when you choose wisely in terms of cancer care, you're actually avoiding financial toxicity and to patients, to their families, but to the society at large. And we, as a group, or the task force that was in charge of coming up with this list, we thought that it is possible that we can, as clinicians, oncologists, we can be good stewards of the little resources that we have on the continent. So in choosing which practice to include on our lists, we had several criteria that were our benchmark. And one of these, or if I mention all of them, one is the practice to be included had to have evidence of low value or harm. And I'm going to share with you the 10 lists. And then the practice to be included also had to be highly utilized on the continent, had to have a cost, including cost opportunity, was also considered in including the practice, should have been clear in terms of wording so that clinicians who are reading this are able to understand what it means. Of course, relevant to the African context, so we didn't copy-paste the Choosing Wisely, Canada or India to our Choosing Wisely practices, but it had, even those that we actually, got from the Choosing Wisely, the US or Canada, India, had to be relevant to our context. And finally, it had to have feasibility of future measurement activity, meaning that if, let's say, for example, after this meeting, I can go to Ocean Road, I am able to actually measure and see if people are choosing wisely in terms of cancer care in Ocean Road. So there are several classes of targets for practices. One is, of course, have no benefit at all. These are practices that we should stop really doing. If you're giving patient treatment that have no benefit, rather harmful, should be stopped really. Practices with marginal benefit, we know that if you're really providing extra 3 or 4 weeks to a patient and with added side effect, that should be stopped. Even if there's a benefit, but it's really marginal, so it should be stopped. Some practices really have no clear benefit. You don't know whether they are adding, survival or quality of life just because there is an improved, PFS or like progression-free survival or recurrence-free survival. These are surrogate endpoints sometimes that are not really meaningful to patients, but rather probably to researchers and clinicians. So these are practices or targets of practices that we are targeting in advocating to be removed from clinical practice. So we published our paper in 2020, and I think some of the names are familiar. Some are even actually here of the authors of this paper. So we titled it Choosing Wisely Africa, 10 Low Value or Harmful Practices that should be avoided in cancer care in Africa. And in terms of categorization, one of the 10 lists is a new suggestion, so basically suggested by the African Task Force, but other 9 were different revisions from different Choosing Wisely campaign across the globe. One item relates to palliative care, 8 items relate to cancer treatment, and one item relates to surveillance or follow-up of cancer care post-active treatment. So I'm going to go through them. I think I still have time so that you see, but I invite you to read the whole paper because it gives context why all these have been done and why we included all these practices. But I think it's good to also add, because I know the audience here is diverse, that we have pathologists, surgeons, and oncologists as well. So one item is do not order tests to detect recurrent cancer in asymptomatic patient if there is not a realistic expectation that early detection of recurrence can improve survival or quality of life. We know that sometimes a patient after treatment, they come to us as oncologists, let's say, and you order a tumor marker that you know that is not going to really, give you anything. For example, if you order, for oncologists, if you order, let's say, CA 15.3 in asymptomatic breast cancer patient, what are you really hoping to get from this tumor marker other than cost implication to patient, and also anxiety that you're going to cause to patient if you find that it's a little bit increased. So that is why we are saying don't order this test if the patient is asymptomatic, and if this test is not going to change or improve the survival or quality of life of patient. Second, do not decide treatment potentially curable cancers without input from MDT. So we highly encourage tumor boards, multidisciplinary conferences, any forum where you have inputs from different stakeholders in cancer care: surgeons, pathologists, radiologists, palliative care team, nurses, and other allied professionals need to contribute to cancer care, especially for curative intent. But we are not saying that you shouldn't do that for also palliative care patients. Do not use surgery as initial treatment without considering pre-surgical or neoadjuvant systemic therapy or radiation for certain cancer type and stages where it is effective and known to improve local control, quality of life, or survival. We know that, for example, surgeons, usually they are first contact of our patients. So sometimes they look at, let's say, rectal cancer patient, stage 3, and they go in and operate. But we know that at advanced stage, they're not really going to achieve negative margins, but rather still this patient is going to need chemo radiation. So instead of doing that surgery, yet we know that neoadjuvant chemo radiation is very good at controlling local disease, but also improving survival. It's always good to consult your colleagues before you go for surgery for diseases that can benefit from neoadjuvant treatment. Do not initiate cancer treatment without defining the extent of the cancer through clinical staging and discussing the intent of treatment with the patient. We know sometimes, at least our experiences, that sometimes there are patients who are not staged and they are started on treatment without staging. So imagine if you start someone on curative intent treatment when this patient is already metastatic, you would have saved this person from having the toxicities from the treatment, and also, some of these diseases can actually have long overall survival if they are put on particular treatment that is well defined by staging. Do not treat low clinically localized prostate cancer without discussing active surveillance. So we know that for low prostate cancer, low risk prostate cancer actually have the same outcome when comparing active surveillance and active treatment. So here we are saying you shouldn't do that for that kind of prostate cancer. So low risk clinically localized prostate cancer. For palliative care, do not delay palliative care for patients with serious illness who has physical, psychological, social, or spiritual distress because the patient is pursuing a disease-directed treatment. So we know sometimes we delay to talk about palliative care, just pursuing active treatment, when ideally you should have started palliative care from the start, from the beginning. I know that Dr. Krishani will talk about this in his talk, but palliative care actually starts from the first time you see a patient. So don't delay palliative care just for pursuing active treatment for patients. And do not use systemic therapy for solid tumors. Patient with the following characteristics, and we include basically the performance status when there's no evidence of the clinical value of adding anti-cancer treatment. Instead, you can focus on pain relief and palliative care. So we are saying for patients who are not candidates for active treatment, don't really pursue active treatment when you can give pain relief and other palliative care modalities. Do not initiate longer course of radiation. Here, in summary, we are saying where it's possible, and actually it's very beneficial to use hypofractionation for our patients. So do not really initiate longer courses, because one, longer courses, we know that they are costly unless you're doing it for your your financial benefit or institutional benefit, which is wrong. Otherwise, we should advocate for hypofractionation, where we have the evidence that actually they are the same as longer course radiation. Do not perform surgery to remove breast lump without histological confirmation. At least for me, my experience when I was a resident here and even back home, I know that sometimes we see patients who come to us with mastectomy before biopsy. This is not evidence-based practice, so should really be stopped. And that's what we are saying. Every treatment for cancer should be based on histological confirmation, and that can be done by doing a biopsy for where it's possible. And mostly solid tumors, we can do biopsy, either open surgery or even with now interventional radiology. Finally, do not use combination chemotherapy, that is multiple drugs, when you can use a single agent. And we know that there's evidence, especially for metastatic breast cancer, that actually single agent is the same as multi-drug for certain type of diseases. So we are saying before you do that, before you put a patient on multi-drugs, you have to assess whether a single agent treatment is not possible. Because with that, you actually reduce the cost, but also you're reducing the toxicity that is due to multi-drugs. So going forward, what we are doing right now is raising awareness of Choosing Wisely initiative in Africa. We are now implementing it in several African countries, measuring it in as well. And as we are planning to keep on updating the list, because as you know, cancer care is ever changing. So we plan to update the list going forward. In terms of raising awareness and also actually validating it, we published another paper looking at what you as clinician on the front line think about Choosing Wisely. And we found that actually most of clinical oncologists are agreeing with what we are doing in terms of Choosing Wisely initiative in Africa. Again, we know that de-implementing a practice is not easy, so we are trying to also publish this paper last year talking about strategies to actually de-implement some of these practices or implement Choosing Wisely recommendation. And finally, as I said, we are now measuring the Choosing Wisely impact in our practice in 3 countries, Rwanda, Ghana, and Tanzania. And to conclude, these are 3 questions I usually say we should always ask ourselves when we are in clinic. Should I request this test? With this test, will it inform the decision to care for this patient that is in front of me? Should I prescribe this treatment? Is it evidence-based? Are there any other cheap alternatives? And have I really considered the patient in the decision that I'm making, the needs of the patient, but also the financial status of the patient? And with that, I would like to thank you so much.